When a peripheral nerve is severed and not reconstructed, the axons will regenerate in a disorganized fashion and form a stump neuroma. Stump neuromas may become symptomatic or painful and result in tingling, burning, and other odd sensations. The current standard of care for surgical management of symptomatic stump neuromas is traction neurectomy. During this technique, a neurolysis is performed and the nerve is exposed. Then the nerve is put under traction and sharply transected. The tension and subsequent cutting causes the nerve to recoil back into soft tissue. However, the regenerating axons still do not have a distal target and will again grow in a disorganized fashion to form another neuroma. Therefore, traction neurectomy inadequately addresses pain-inducing neuroma formation. The Axoguard nerve cap is a surgical implant designed to protect the end of the peripheral nerve by separating it from the surrounding environment and reduce the development of a symptomatic neuroma. Once appropriate neurolysis has been performed and the neuroma is exposed, a sharp transection is made. If the nerve fascicles do not appear to be healthy, a more proximal transection back to healthy fascicles may be required. Once debridement is complete, the nerve diameter is measured and the appropriate diameter nerve cap is selected, accounting for postoperative swelling. An intubulation stitch can be used to introduce the nerve stump into the Axoguard nerve cap. First, a suture is passed from outside, approximately 2 to 3 millimeters from the open end of the nerve cap. The suture is then passed transversely through the epineurium of the nerve stump, at least 1 millimeter from the cut nerve face. The suture is then passed back through the nerve cap from inside to out, approximately 2 to 3 millimeters from the open end. The suture is then pulled, drawing the nerve stump into the cap prior to securing the suture. A second suture can also be placed to secure the nerve stump inside the nerve cap. The nerve stump should be aligned linearly within the cap and should not touch the internal partition. Once the Axoguard nerve cap is securely sutured onto the nerve stump, the distal end tab may be used to secure the device away from the surgical incision and surrounding soft tissue. The subsequent nerve outgrowth is contained within the Axoguard nerve cap as the material gradually remodels into the patient's own tissue. In a preclinical rodent model, the application of the Axoguard nerve cap effectively reduced hyperalgesia associated with mechanical stimulation of peripheral nerve end neuroma compared to neurectomy. At 2, 8, and 12 weeks, the pain response in the nerve cap group was statistically lower than the neurectomy group. The Axoguard nerve cap is designed to protect the peripheral nerve end and reduce the development of symptomatic or painful neuroma formation.